Over the past decade, we have made significant improvements in the way we deliver care, as well as outcomes with lung cancer. Many of these advances have come because we've been able to apply targeted therapy and immunotherapy for our patients with non-small cell lung cancer. But having said that, lung cancer is complex. There are a lot of variations, there's a lot of mutations, and our historic gold standard to test for these mutations has been to use tissue testing. However, we know that tissue testing is not always feasible, either due to lack of adequate tissue or really availability of tissue in the vicinity where the patients are being seen. For example, I certainly see my fair share of patients that get diagnosed at an outside hospital, and sometimes the tissue is just not enough, or it doesn't make it to our hospital or our center in time. Liquid biopsies have become a really nice, easy, facile, non-invasive way for us to really detect these mutations, and as a way to offer personalized precision medicine to these patients. Liquid biopsy really involves obtaining blood, separating it into plasma, and then really looking at the cell-free DNA or the circulating tumor DNA component and analyzing that with gene sequencing to give us a sense of the molecular signature of the patient's tumor. We conducted a study at Penn Medicine to really discern whether or not adding liquid biopsy to tissue testing improved our ability to detect mutations, ability to really administer targeted therapy to patients. We started off with about 323 patients with non-small cell lung cancer, where our intent was to proceed with concurrent tissue and plasma testing. We had about 29% or 30%, or about a third of our patients where we proceeded with plasma testing alone. And these were patients where either tissue was inaccessible or it was due to physician or patient choice. In the rest, 2/3 of the patients, even at an academic center like ours, we found that tissue biopsy could only be completed in about 40% of the patients. And often this was dictated by the amount of tissue that we had, or sometimes tissue is just deep and there's necrosis and we're unable to get a good biopsy sample. When we looked at these 2/3 of our patients, we found that by adding liquid biopsy, we were able to improve our detection of these mutation testing from about 20.5% to 35.8% using both modalities. And this just highlights to you that there were additional patients that then we were able to treat with a targeted therapy, often a pill, and were able to avoid the toxicities that were associated with chemotherapy or chemoimmunotherapy, and really yield successful outcomes in these subgroup of patients. Liquid biopsy is an important tool that must be used, especially as we've seen new FDA approvals come to the forefront. Over the last few months, we've seen drugs targeting RET, MET being approved, including our previous 5 targetable alterations: ALK, BRAF, we have EGFR, we have ROS1, now we have RET, MET, and of course we have NTRK, which, although very rare in non-small cell lung cancer, can still occur, and there are approved drugs to be able to target this alteration. So more than ever before, I think liquid biopsies are an important tool. They offer a minimally invasive way to test a patient's tumor, and certainly should be employed. Having said that, there are a couple of limitations that should be addressed for liquid biopsy. There are certainly issues with tumor shedding. So not all patients may have detectable tumor DNA in the circulating bloodstream, and it's often associated with limited stage. So patients that have intrathoracic disease alone may not have enough tumor shed for us to be able to detect a circulating tumor DNA mutation. And those are some limitations that we must keep in mind when we apply liquid biopsy testing, remembering that in those situations, tissue biopsy is certainly still our gold standard. And with that, I will end this video. Thank you so much.